um, especially on a relatively short notice for this webinar coming together, but looking forward to the conversation today. For those of you I don't know yet, my name is Samantha Jurdak. I'm a co-chair of the Maternal Health Caucus and Maternal Health Supplies Caucus, and also an associate director at Results for Development. I want to note that yes, I work with R4D and was very involved with this project that we're going to present on today, but I'll be more in a listening mode today. I'm excited to be able to wear more of my MHS caucus hat today and be in more of that listening mode and hear from our colleagues on the findings as well as their perspectives. So today R4D is joining us to share out findings from a multi-country market assessment on maternal newborn child health and nutrition products that was conducted in 2024. Omar Khan, he is a program officer at R4D, sitting on the market shaping practice. He's going to be presenting the summary findings from across the 3 countries. And just to note, Omar comes with a variety of backgrounds in the health system strengthening and market shaping space. He's worked on a number of projects related to MNCH as well as nutrition in both sub-Saharan Africa and South Asia. And then the presentation will be followed by Q&A. We want to hear a variety of perspectives on why this type of market data and insights, like why these things are important to our work to improve access to maternal health supplies, and also importantly, how to turn market insights into action. So joining us for this discussion, we have a cast of really great speakers. We have Dr. Tom Mingay. He's Chief Pharmacist and Head of the Directorate of Health Products and Technologies at the Ministry of Health in Kenya. We have Maria Sala, who is a public health physician and all-around expert in health system strengthening, supply chain, and health financing reforms for MNCH products in Nigeria. And then last, but certainly not least, we have Adriana Sousa. She's the engagement manager at MNCH-N, and very excited to have Adriana join us to provide a bit of that private sector perspective that's really critical to our discussion today and to our thinking about creating sustainable maternal health supply markets going forward. So in addition to the housekeeping items that Laura mentioned regarding having your microphones on mute if you're not speaking, as well as that will be recording. I wanted to say that if you have any questions or comments throughout the presentation, you can add them in the chat and we'll either address them there or we'll have time at the end to respond. We also want to open up the discussion to you all after our speakers have had a chance to make their remarks. I'm imagining the presentation and remarks from the speakers will take about 40-ish minutes, so we'll have plenty of time at the end to hear from everyone and have a real dialogue. So when that time comes, please feel free to put your comments in the chat, or you can also raise your hand and I'll kind of moderate the facilitation of folks so that we can have a chance for everyone to speak. Without further ado, I will hand things over to Omar and looking forward to the discussion. Thanks so much.
Thanks so much, Sam, and thanks everyone for joining today. If we could go to the next slide. Thanks. So yeah, as Sam mentioned, I'll be providing a really high-level summary of findings from our MNCH-N market assessment across Ethiopia, Kenya, and Nigeria, but I do think many of our findings and the way we've tried to frame our takeaways today are generalizable to understanding some of the MNCH market dynamics across low and middle income countries. Next slide, please. The MNCH-N market assessment was designed and implemented by Results for Development with funding from the Gates Foundation, and we partnered specifically with Pract Health Consulting and MNCH-N in Kenya, as well as Market Access Africa and PBR Life Sciences in Nigeria to support data collection and analytics. This market assessment is also building off of a 2020 MNCH market assessment that R4D undertook with some overlap in geographies. So you might find some findings that incorporate both market assessments in this analysis. We wanted to give a special thank you to our many stakeholders that we engage with for their both engagement and support, because without them, this assessment would not have been possible. So across Ethiopia, Kenya, and Nigeria, a whole suite of government stakeholders really came together to speak with us about this market and the market dynamics that they've noticed, as well as non-governmental stakeholders. So this is far from a comprehensive list, but just a starting thank you for everyone who's participated in this market assessment. I'm now going to talk a bit about the project approach before diving into some of our key findings. So R4D was really asked to do this market assessment for two reasons. One, because donors were looking to use the information to inform investments to improve the MNCH-N market, but also because governments were particularly interested in understanding in a more detailed and evidence-based manner some of their own MNCH-N market dynamics for their own policy implementation and proposals. R4D's market assessment was focused on 15 products, both emerging and established, in public facilities across Ethiopia, Kenya, and Nigeria. And these three focus countries were chosen in part because they represent a variety of health system organizations. So specifically, Ethiopia is highly centralized as a health system. So the market assessment was focused on the national level. In Nigeria, where most of the health system is decentralized to the state level, particularly service delivery, 10 priority states were selected for state level market assessments. And in Kenya, where parts of the health system are both decentralized, but some of the planning pieces are centralized, both the national level and county level data collection and analysis was undertaken. Next slide, please. So I've been saying market assessment a lot, but I also want to go into a bit more detail of what we mean when we say market assessment. There are several market characteristics when you're talking about an essential health or nutrition commodity, which are broadly agreed upon by a variety of market shaping experts as defining and shaping and enabling, in this case, the market for these commodities. And so we explored some of them in detail for this assessment. In scope of this market assessment were the policy and regulatory enabler, the financing enabler, the procurement enabler, and the supply enablers. I want to note specifically that looking at service delivery and facility usage was not in scope in this market assessment, and that definitely shapes our understanding of the market in this assessment. To understand how these four market enablers shape the MNCH market in countries, R4D's market shaping practice has put together a framework that looks at several healthy market characteristics, and then we, with our quantitative and qualitative data collection, try to determine whether these healthy market characteristics were being met in the MNCH-N markets in these focus geographies. Next slide, please. To determine whether these healthy market characteristics were being met in focus geographies, R4D took an iterative hypothesis-driven approach as shown here. We've started first by developing hypotheses and key questions based on both existing market shaping frameworks and our available analysis from the 2020 R4D MNCH market assessment. We and our partners then conducted data collection for several months on both the national and subnational level before moving into data cleaning and analysis with an iterative approach where both data collection and analysis was iterated upon based on emerging findings before finalizing the 2024 market assessment for share out. Next slide, please. Just to show here, we also wanted to demonstrate at a high level the kind of data that was being leveraged to understand whether healthy market characteristics were being met. So we collected data at the global, national, and subnational level with a variety of data types to inform us about all four of the market enablers that I mentioned earlier that we were focusing on for this market assessment. Next slide. Thank you. So I'm now going to talk about the key findings first at a really high level and then with a bit more detail on some of the analysis that we've undertaken. Next slide, please. This slide is really just a high-level summary slide that goes through the key findings as they relate to the healthy market characteristics I mentioned earlier. And I'll double click on some of the findings throughout the presentation. At a really high level, our finding was that the only healthy market characteristic being consistently met across the MNCH and commodities and focus geographies was that normative guidance is largely aligned to global recommendation across countries for these products. For the other healthy market characteristics, we found key challenges impacting market health, which I'll talk about in a bit more detail. Next slide. This slide is really context setting about the main outcome and impact that we were looking at for these market assessments, since, as I mentioned, commodity delivery and facility usage were not in scope. We used public sector facility availability as a proxy to understand the overall outcome of the different market enablers in ensuring consistent access to these essential MNCH-N commodities in facilities. Our key takeaway is that availability varies from commodity to commodity, but on average, it's around 62%. which is lower than the minimum target of 75% set by multiple governments. However, double-clicking on some products where we have availability data from the 2020 market assessment and the 2024 market assessment, we're finding that MNCH-N availability is increasing, which is a good sign for market health. But we do still want to understand what's shaping the lower than average or the lower than targeted availability in some of these products. Next slide. I'm now going to start diving into sort of by enabler, some of the key findings that we found to be challenges and opportunities in the market. So starting off with financing, a key takeaway that I wanted to highlight here is that one thing we found is that the MNCH-N market has a high level of government stewardship and funding, which may differ from other commodity markets such as family planning. Government stewarded doesn't necessarily always mean government financed, which is an important distinction. And one key demonstration of this is the SDG pooled fund in Ethiopia. But it does mean that governments are able to make their own prioritizations depending on need, which is a really important step in market health. Understanding whether funding is government stewarded or not is also a really important context setting step for understanding the type of market interventions that would be impactful and beneficial for the market. Next slide, please. Although government stewardship in the MNCH-N market is a good sign for longer-term funding health, this assessment did find funding resources overall to be fragmented, unpredictable, and unsustainable. And here we pulled out data from 2016 to 2023 in Ethiopia, since as a centralized health system, we were able to leverage both the 2020 and 2024 RFP MNCH market assessments. In a centralized health system as Ethiopia, we found both government and donor finance commitments to decrease from 2016 to 2023, and the biggest drop-off to be from 2018 to 2019, preceding several health system shocks that may impact MNCH-N financing priorities, such as the COVID-19 pandemic, which again raises concerns about longer-term funding sustainability and health. Next slide, please. Moving now into the procurement analysis, I'm going to focus on talking about these sort of takeaways as either in a centralized health system or decentralized health system, because we had different takeaways depending on the type of health system. So in centralized health systems for procurers, we found that volumes are insufficient to meet demand, in part because of the technical capacity and capacity strengthening needed for centralized procurers. So for example, in Ethiopia, the centralized government procurer, EPSS, is able to procure almost all the MNCH-N public volumes, and the only exception that we found are really emergency orders through UNFPA or UNICEF or COVID-19 donations. But despite that ownership of the MNCH-N procurement, we did find significant lead time delays, with 20 to 35% of orders taking longer than a year to be fulfilled, disrupting supply plans. Qualitatively, stakeholders indicated a variety of interrelated reasons leading to these delays, including technical capacity constraints for EPSS, as well as broader challenges such as a lack of Forex in the country. Next slide, please. I think, yes, in decentralized health systems, we also found that volumes were unable to meet demand, but that the key driving factor was slightly different. So in these contexts, we found that geographic fragmentation can lead to reduced value for money. So for example, in Nigeria, here we're showing in 2023, 9 of the 10 priority states and the volumes and weighted average price of misoprostol in those state orders for 2023. And you can see a high variation in the order size and price, which don't necessarily correlate. So there are some states where there are high orders and low prices, but some states where there are high orders and high prices. To highlight the impact of this fragmentation, we demonstrated on the right-hand side a hypothetical of the total, like the hypothetical total volumes of misoprostol that could be purchased if all 9 states are able to leverage the lowest average price from 2023. If they were able to do so, they would be able to almost double the volumes of misoprostol purchased among the 9 states with the exact same financial envelope available. Next slide, please. Thanks. We not only found unique dynamics impacting the procurement space depending on health system organization, but also a similar dynamic informing supply side challenges. So for example, here on the left-hand side, you can see in a decentralized health system, we find high levels of supply side fragmentation as well. Although for magnesium sulfate 50% 1 milliliter, There's only one supplier registered with NAFDAC, the national level food and regulatory body in Nigeria. 9 priority states were found to be purchasing from 16 different suppliers, distributors, and wholesalers, and a majority of them are active in only a single of the priority states, indicating high levels of subnational geographic fragmentation among these suppliers. In a more centralized health system such as Ethiopia, although that type of supply side fragmentation may not be a concern, there are still concerns about whether there is a sufficient supply base registered with the national regulatory body, such as here where 6 of our focus commodities were found to have 6 or fewer suppliers registered, which is a cause for lead time delay when it comes to order tendering among these suppliers. Next slide, please. Overall, we use pricing trends as a great proxy to measure some of the market challenges that we're discussing. So for example, for several of our key priority products, such as amoxicillin 250 milligrams dispersible tablet, azithromycin 250 milligrams, misoprostol 200 micrograms, and oxytocin 10 IU per milliliter, we found one or more of the weighted average prices over the 5 years of this market assessment. For one or more of the countries, at least, the weighted average price over the 5 years of this market assessment is higher than the UNFPA or UNICEF catalog price, despite more stringent quality requirements from UNFPA or UNICEF, which indicates market inefficiencies in these countries may be driving the weighted average prices up. Next slide, please. We also found price to be highly variable across not just country to country, but within a geography, as shown here. On the left-hand side in Kenya, we found price to be highly variable from county to county analysis, as demonstrated in these box plots for amoxicillin and misoprostol weighted average prices on the county level. And we also found price to vary in part due to who facilities or counties were purchasing from, as demonstrated by analysis that looks at markups on purchasing depending on the type of private sector retailers and wholesalers that some facilities or counties were relying on to fulfill need that they had identified when sort of centralized public sector procurement channels were not available. Next slide, please. Lastly, we also analyze quality assurance for the market, which is a really challenging facet to analyze when it comes to market health. For this market assessment, we're defining globally quality assured suppliers as suppliers registered with the WHO PQ or other stringent regulatory authorities, which we know to be an imperfect measurement of quality. But given that after quality market assurance is hard to come by in some of these focus geographies, we had to use it as a proxy for quality assurance. The main takeaway here was ultimately that there's an absent evidence base on the country level to determine whether products being procured are quality assured or not, which also means there isn't the evidence to inform decision makers for procurers on whether they should be prioritizing more stringently quality assured products at a slightly higher price. I did also want to highlight here specifically that there was only one example of any of the focus keys we found where a majority of the WHO PQ or stringent regulatory authority certified suppliers were registered in a country. And that was for amoxicillin 250 milligrams dispersible tablets in Ethiopia, which we know to be a product of market shaping intervention efforts in Ethiopia specifically for that product. And while that sort of intervention may not be generalizable, it demonstrates that there are market shaping opportunities that can improve quality assurance in the supply base and on the country level. Next slide, please. I want to say thank you so much for taking the time to listen to some of these high-level takeaways. This was a far from comprehensive presentation of our findings, and we'll be disseminating more detailed reports on the country market findings in the coming months, so country-specific reports, as well as the globally quality assured supply list that we use for this market assessment. So keep an eye out for those sort of findings. And I'm now going to turn it back over to Sam and the panel to talk through the implication of these findings for decision making. But please feel free to put any questions about the specific content in the chat for me. Thank you again.
Thanks so much, Omar. Really appreciate you taking the time to share out these findings. And I know it was a high level kind of rapid readout, but I hope it kind of gives everyone a taste for the types of market findings we're able to pull together when we take a really diligent evidence-based approach. I'd love now to turn it over and spend the rest of our time here today on more of a discussion. So I really hearing from our speakers and their perspectives on kind of not just why these matter, but why these findings matter, but why they're important as well. So maybe first up, I can call on Dr. Menge and Maria. I'd love to hear your perspective on, why these insights matter, particularly in your country context in both Kenya and Nigeria. What surprised you most from the market assessment findings, or where do you see these insights supporting priorities in your country? Dr. Menge, would you like to respond first?
Thank you very much, Samantha, and thank you for all the effort that went into making this assessment possible. I just want to confirm, first of all, that I'm audible.
Yes, loud and clear.
Yes, so the assessment covered very many products. Some of them are products that we can consider to be relatively mature. And there are a few products that are relatively newer in the space of MNCH. Specifically in Kenya, there were findings that identified 4 products that do not comply either with our essential medicines list or are not in our guidelines for management. And I think it's those products that sort of like made the landscape look differently. For me, I think one of the concerns that I had in looking at this information that came out of this survey was the fact that whereas our regulatory space is very, very well defined, but we still find ourselves subjected to quality risks, especially for some of the products. And the quality risks are sort of like greater in the private sector than in the public sector, which was really surprising. Because you'd expect maybe, I mean, for me, it was good to realize that the public sector goes into more stringent ways of establishing that quality is maintained throughout the cold chain. The price variations were of concern also, where we had close to 82% variation in price markups. But I think it is good. Now, some of the things that came out in this survey was the fact that there was a conclusion that procurement of these items is not informed by the disease burden. Well, that was an interesting finding in the sense that we take quite a lot of time to allow our medicines lists to be guided by the disease burden. And for us to be able to look at a lot of these items not being guided by disease burden, I think it's something that we possibly want to see how that was interpreted. My final comment was on the issue of our health system. We run a devolved health system where we allow the county governments to have some independence on the method of procurement, but that notwithstanding, we have procurement agencies that use the principles of pool procurement. I am not surprised that we realize that whenever counties make decisions to utilize these pool procurement agencies, for us, the Meds and the Kenya Medical Supplies Agency, then they have good quality products, but also competitively priced products. And whenever they move out of this procurement system, then they put themselves in a situation where their prices cannot be managed. It was a good survey. And for us, it sort of like, first of all, affirms the procurement systems that we have been putting in place, but also speaks to the fact that we can be able to use this information to change policies in the area of maternal and child health. Let me also just comment that of the 4 products that are not within our essential lists, we have a mechanism that is in place, and I think it was noted in the report, where the various organizations that possibly feel that this should be a product that needs to be used can be suggested. But I also want to comment that for the products that were not within that list, one of the observations then we made was that there are alternative formulations that are available, and that is what is currently in use. Let me stop there, Samantha, and
Dr. Menge, thank you so much. Very concise, very comprehensive overview there, and really appreciated the I guess market characteristics and the findings that you were seeing as being most interesting and most useful as you're thinking about the policy work that you're focused on. So the challenges around quality, around price, but then also how some of this evidence base around the benefits that are seen when counties are procuring through KEMSA and MEDS, these more centralized procurement mechanisms, how that you're seeing that supports kind of the thinking in country around how to improve quality and price and reduce that fragmentation. So really appreciate your perspective there. Maria, I'd love to hear your perspective as well, coming from Nigeria, especially given that you've worked with so many different partners over the years, but all kind of targeting these challenges around how do we improve our MNCH markets. So Maria, the floor is yours.
Thanks, Samantha. Apologies, I will keep my camera off. I noticed Dr. Menge's voice was going off, so I thought my internet might be a bit thanks. Yeah, so thanks for your presentation, Omar. I think for Nigeria, one thing that really struck me, and I think I've mentioned this to you, Samantha, was the price variability across the 9 or 10 states in the graph. As I mentioned, we do have a very fragmented procurement system. Each state runs its own procurement. And even within the states, we do have additional fragmentations. For example, in the private sector, they source their own products. There are regulatory agencies that register suppliers, wholesalers, distributors. However, where they source their products from has been a concern. Many source their products from open markets, and again, those prices, are not regulated. On the government side, the government has put in a lot of efforts, I would say, in the last few years at the state level to centralize procurement through the establishment of drug management agencies. And one example, I think, would be the support that GHSCPSM, so that's the Global Health Supply Chain Procurement and Supply Management Project, had provided over the years to establishing drug management agencies and helping them set up and attempting to establish pool procurement across the states. And I think this data really emphasizes the importance of having those kind of systems where we're able to pool demand across states and get the best pricing. It was very striking to see how much more products these states could have gotten if, we had been able to pool the demand across states, or even if they could have saved money if those procurements were actually based on the quantification or the disease burden. But we know that this assessment also showed that many of the decisions were not taken based on the burden of diseases. So I would say that for me, that graph really is an important tool for advocacy, for pushing and making the case for pool procurement across the states. On the side of supply fragmentation, I think I touched on this a bit, but what I wanted to highlight is that there's been a presidential, I would say, declaration on, local manufacturing of medicines, improving the value chain of healthcare products, and that includes devices. And so if we're able so looking at all of these many suppliers, if the states are able to come under one single entity, and again, just to say that an attempt has been made, there's a project funded by the Gates Foundation, which links the local manufacturing association, I believe it's called the Pharmaceutical Manufacturers Group of the Manufacturers Association of Nigeria. It has linked that entity with states, whereby they sign an MOU, they're able to get credits, and they get access to the medicines directly from the manufacturers. Now, this mechanism, again, doesn't quite pull demand, but it ensures that states have access to quality medicines directly from the manufacturers. As far as quality goes, I think that was also one component of the assessment. There have also been efforts to improve quality and get many of the MNCH products manufactured in Nigeria registered with WHO, so with a stringent regulatory authority. I believe 2 or 3 products are now registered globally, and so these manufacturers are better able to sell their products outside of Nigeria. I think this is also a very important point, in that it expands the market for local manufacturers, makes it I think more viable for some of the investments that they're making. There was also a point that Umar made on I think it was on the financing. So those also are not quite clear. In Nigeria, we have various mechanisms that are financing procurement of medicines, and each of those ones, kind of source their own medicines. So that also further increases the fragmentation that we see in the market. For example, there's the Basic Healthcare Provision Fund, and that's kind of a special fund that's funded straight from the federal government, and it allows the guidelines for the Basic Healthcare Provision Fund actually allow participatory facilities to source their medicines through some accredited vendors, but in some states, these accredited vendors are not procuring from the Central Procurement Agency or the Drug Management Agency in that state. It's not quite known where they get their products from. Are they registered? Are they the same products? Are they getting those from local manufacturers? So those are some of the things that I feel we need to look into. How do we harmonize the financing from all of these sources and route them through one central procurement mechanism, or several, but at least those that would give the best value for money when the states are procuring products? Thank you. I'll pause there.
Thanks so much, Maria. Really appreciated some of the clear examples you're able to give around what's currently some of the initiatives underway in Nigeria, and tying it back to some of the findings that we're seeing here. I think there's definitely opportunities to connect the dots between what we're seeing as the current status in the Nigerian market and some of the initiatives that are underway to help improve maybe how those initiatives are being implemented around advocacy tools. Also, this last example you gave around the connection between the health financing and how that ties into procurement and supply side fragmentation, and how we can structure mechanisms better and differently. So really appreciate those very tangible examples from Nigeria. And then finally, and I think very importantly, as we're kind of getting to, especially with what Maria is sharing, market insights are important, but it's really how do we turn these into action? That's what we want to be able to get to as a group within the Maternal Health Supplies Caucus. And so Adriana, I was hoping I could turn to you now to speak a little bit on what may be the bottlenecks to turning these findings into action, and is there any data or evidence that you think we're missing, particularly from your private sector Maisha Med's perspective?
Thank you. I'm just turning my camera on to say hello to everybody, and to thank you, Samantha and the R4D team, for inviting us. It's a pleasure to be here. So I'll now turn my camera off. As Samantha mentioned, I'm part of the Maisha Med's team that performed this analysis focused on MNCH consumption in the private sector. And when we say private sector, we mean these private pharmacies and clinics. I'll start by sharing that thanks to this work, we've hopefully shown how important the private sector is in the MNCH space, given that we found that half of the sales of some of these products, like misoprostol, amoxicillin, azithromycin, are taking place at these private pharmacies and clinics. So I don't think this was particularly clear in this presentation. So I'd recommend everybody here to take a look at the full report made available by R4D today, which contains even more interesting findings overall and for the private sector specifically. So I'll start by answering the question on which data or evidence we're missing in this analysis. And for context, I wanted to talk about the data sources that we've used to run this analysis. So the first one is our pharmacy level data from around 1,000 private pharmacies and clinics that use our business management software. And this is data from 2024. So the software allows them to record every sale to patient, the brands, the wholesale and the retail prices, the margins, the manufacturer, etc. So due to the nature of MNCH-N's operations, these pharmacies and clinics serve primarily low to middle income populations based in peri-urban and rural areas. And for that reason, the analysis is missing sales from high income, high volume facilities. That's one thing to take into consideration. Also, we don't have private hospitals or maternity wards data because they're not using our software. So we're probably missing sales from some of these products, particularly for injections like magnesium sulfate or hydralazine. The second data source we've used is export data or shipment data, in which we're able to track down every commodity flowing from India to Kenya, track its origin, its ex-manufacturer price, and the organization that is importing it. So we can see what's flowing into the private sector specifically. And we've used exports from India, but throughout the analysis, we noticed that some of the products are actually being imported also from Bangladesh and China, like misoprostol, gentamicin, or dexamethasone. So adding this layer of additional data would help us improve the total private sector consumption estimates. We also think it would be valuable to replicate this private sector analysis across other countries like Nigeria, as we've seen, but for Tanzania and Uganda as well. Right now, we have a network of over 4,500 pharmacies and clinics reporting, capturing 2 million patients every month. So we think we have relevant data to also support similar analysis. As for your first or second question about what's limiting turning these findings into actions, so in part, we think a shift in mindset is needed. So historically, analysis and interventions have been largely public sector driven. But the more we do this analysis and the more we understand the private sector, the clearer it becomes how critical it is for patient access, and not just for MNCH, but also for family planning or even malaria and other commodities. So we think it's essential that focus and investment strategies do reflect this and extend support to the private sector as a key part of the solution. We see access to these findings also as being a bottleneck. So many times we see these good analyses being done and sometimes replicated, but they end up not being disseminated enough. So we need to promote sharing. We need to get this evidence in the hands of decision makers, governments, but also private players like local manufacturers. And at MNCH-N, we're very committed to do this. We're actually running a project in June funded by UNITAID, where we will be sharing PPH data, so oxytocin and tranexamic acid data beyond HIV and malaria from the private sector, free of charge to local manufacturers to help them improve their decision making. I think another bottleneck we deal with many times is the lack of incentives for integrating and licensing new data. So as we've seen in this particular analysis, this type of analysis only makes sense when you put them side by side with public sector data to understand whether the private sector is indeed selling more volumes or less volumes in comparison. But many times integration of this data sets is costly and it's time consuming. We would love to have our data available on JFBVAN, for instance, but funding is still a barrier for now. And the same goes for real-time data. So I am a bit of a suspect here, but sometimes we see decisions still being largely focused on public sector data only or on survey data. So we think that shifting towards real-time insights would help us understand new trends, identify new gaps and opportunity as they happen, but also help monitoring the impact of these interventions when they take place. So, and lastly, promise, I think the last bottleneck that tends to affect everything that I've said so far is funding. Not having enough funding streams does prevent the creation, the integration, the dissemination of these findings, even training of new users and their analytical capabilities around this data. And we think that's probably the largest bottleneck hindering meaningful action and impact in this space. Thank you.
Adriana, thank you so much. I think everything you raised was incredibly valid, and I'll say from working with the Maisha team on this market assessment, it really improved my own knowledge and awareness around just the breadth of possibilities that are possible, not just the breadth of possibilities that there are with the private sector, not just in terms of solutions for the future, but also how much of, as you're rightly pointing out, how much of the market insight we're missing by focusing solely on the public sector lens and not looking at that private sector as a key player and a key component in the market. So really appreciate you emphasizing those points as well here. I wanted to turn now to the participants. This is kind of an open time. I would love to use this as kind of a launch pad, this discussion for how we as a maternal health supplies caucus see the use of findings like this. I'm sure, this is not the only market assessment that's been done. A lot of members here, whether you're government or private sector or an implementing partner or a donor, we all have rich data that can help inform how we can take action. And I'd love to hear from you all on if there's some tangible or specific ideas you have for what we can be doing next to kind of bring some of these pieces together, as Adriana was mentioning. So let me turn now to hear if there's anyone from the group that wants to speak. If you want to just raise your hand, I can then call on people to come off mute.
There are some questions in the chat. I think I see 2 or 3 questions.
Thanks, Maria. Maybe Yusuf, would you like to, from HSDF, would you like to kind of provide a little bit more voiceover and context for your question here around the findings in Kaduna State, Nigeria?
Hi, Samantha, and hi, everyone. Thank you for this insightful presentation. It's very impactful, and I think I've learned quite a lot. So actually, I was just trying to place a kind of a scenario, just trying to contextualize the findings to see what is obtained in the Nigeria typically. So that's why I was just giving an example for Kaduna State scene. So I just want to understand. We know that Kaduna has quite a lot of robust supply chain system. At some point, they're even using some kind of drones to deliver some commodities across different facilities and so on and so forth. So looking at those kind of situations, so that's why I was just like trying to understand if and what lessons from your own analysis for could be most relevant for those kind of situations. Thank you.
Thanks so much, Yusuf. Maybe let me see if there's anyone else who wants to share a question, and then we can turn it to the speakers to see if there's remarks. Thanks, Dr. Menge. I'll make note of that. Maria, Adriana, would you like to respond to Yusuf's question? Happy to hear from you all first, and then I can chime in as well. Omar, please feel free to respond too.
Yes, so I don't quite remember details of Kaduna's presentation, findings, I beg your pardon. But yes, I agree that Kaduna has a lot of supply chain interventions that have happened over the years. I believe they have one of the strongest DMAs. But I think what can be taken away from this, I made this point earlier, is around pool procurements. The graph kind of anonymized the states, so it's hard to tell which one is Kaduna or not. But almost all the states were actually procuring medicines, or that particular medicine at a higher price than was the benchmark, which is the UNFPA price, the price in UNFPA's catalog. And so I think for me, that would be the main takeaway. Re-examining, where these products are sourced from, the quantifications, how they are done. Many states are now doing quantifications. They are using disease burden, yes. However, are these quantification exercises linked with the actual procurement? So we go through all of these exercises, but are we linking that with the procurement? Are we buying exactly what is needed and supplying it to the facilities where they are needed? I know there are issues of funding constraints, but these are some of the things that we need in order to make some of the decisions around budgeting and prioritizing MNCH commodities, especially now that MNCH is having its own day. I think in Nigeria, there's a large intervention that the federal government is running. And so for me, this is the beginning of, shifting the conversation around moving towards more of a needs-based procurement rather than just because we're running in many states free MNCH programs, but largely the commodities are not enough. So this it's now time to move towards buying exactly what is needed at the best price, looking at value for money and health outcomes. Thank you.
Thanks, Maria.
Yes. So we did not run this analysis particularly for Nigeria. So our support here was focused on Kenya. But some analysis that could be replicated in the case of Nigeria would be, for instance, looking at the prices. In Kenya, we see that some products have very high markups, like was shown here in the presentations, particularly injections or temperature sensitive products. So we could analyze which factors are indeed influencing the prices that patients are paying. We could also understand what is the role of local manufacturers compared to what is being imported, or also understanding what products are registered in the National Regulatory Agency, in this case NAFDAC, to also understand if these pharmacies, clinics, and drug shops are selling what are supposed to be the most let's say, I don't want to say high quality, but at least to be sure that these products are at least approved and registered under the NRA. Yeah, I think that's it. Thank you.
Thanks, Adriana. I think that perspective from Kenya is helpful though, and to see how we could kind of make some comparisons. I think Ozzy, I see you're on the line as well. Ozzy worked with us at Market Access Africa on the Nigeria assessment. So Ozzy, I'm putting you on the spot, but if you wanted to chime in with your own thoughts, I welcome you to jump in. Okay, might not be able to get Ozzy's connection, but that's okay. I think Ozzy, if you want to chime in the chat, very mumuch welcome your perspective here. The other question I'm seeing in the chat, Dr. Gatitu, maybe if you wanted to respond to a question we have from Megan around what might be the cause of the disconnect between the role of disease burden and planning. We saw that in Kenya, yes, but we saw it across all 3 geographies, and I think that's a challenge that most countries face. So I'd love to hear your perspective on what might be some causes for those that disconnect.
Can I actually clarify the question?
Oh, sure.
Sorry. It was actually the point Dr. Menge, I think, said during his sort of reflection that one of the interesting things about the findings was that the report sort of indicates that perhaps product planning doesn't feel like it reflects disease burden. And yet in country, they feel like they're taking a lot of time and really deliberately exploring disease burden when they do their planning. And so kind of it was a surprise, right, to see that it was reported one way, and yet the feel from the team doing the work was actually quite different. And so I think that was actually the disconnect I was kind of more interested in, was like, how does that, like how, when we aggregate things into a market assessment like this, like what are we losing about, and how are we looking at, for example, the role of disease burden if it's felt one way but then also reported differently. But the broader question around disconnect is also interesting. But yeah, it was more about kind of, maybe it's more of a methods question, right, or a definitions question, and what we can learn from also Dr. Menge, who's saying no, we actually do this quite often. So that was more my curiosity. Thanks.
Thanks so much, Megan. Yeah, please come in.
Thank you. So I could just come in on that. I thought I was going to follow up the conversation after some time. But one of the things that we've realized is that the problem with the fragmented procurement, where you're allowing governments other than a centralized procurement system, is that a lot of the data that is collected to look at disease burdens is collected at a national level. And therefore also a lot of the measures that you do to find out how well you're doing in terms of health outcomes is done at a national level. Yet when you find that procurement is done at regional levels, and for us at county level, the commitment is not always to follow procurement as per the expected national data, but possibly based on their quantification needs. And sometimes quantification may not be able to follow disease burden. So I think that is always going to be a challenge for fragmented procurement as opposed to centralized national procurement. Thank you.
Thanks so much, Dr. Menge. I think that's a very valid point. And we see it both in decentralized systems, but also in more centralized systems like Ethiopia. That disconnect between between how data is accessible and shared, but and like the real-time data that Adriana was mentioning, from the facility and county level up to the national level, is really creating some bottlenecks in terms of accurate supply planning. I wanted to pull on also Minnie in the chat, your question here around how are countries coordinating with private sector procurement to ensure quality? I think anyone could jump in on this, anyone that has an example. Adriana, Maria, obviously from our speakers list, you might have some clear examples, but yeah, I open this to anyone else that would like to chime in. Daniel, hi, welcome.
Hi, everyone. This is Dan Rosen from MNCH-N. What I would say is that it's the job of the regulator to determine quality in the market, and to say whether a product is or is not allowed within a country. Our experience of working with private wholesalers is that if the regulator says it's okay, they will say, you know, it's not my job, I will sell it. If it's the cheapest, I will sell it. What I think that then potentially needs to be more of is more funding for regulators for post-market surveillance, to test the quality of products in market, there is an overemphasis right now on registration of products and an underemphasis on continual testing would be my personal view. Back over to you.
Thanks, Dan. I think that resonates a lot with also just in terms of our ability and the market assessment to find a clear and consistent way across countries to look at quality and to kind of have a proxy to measure quality. As Omar was saying, it's really challenging when there's not that investment in the post-market surveillance pieces. I see there's a number of different threads that I would love to kind of, I think we can find time to have another webinar type discussion on this matter that we can, I think, reach out to those of you who have joined around quality and also discussions on strategic purchasing, procurement purchasing, and what that might look like in the different country contexts. I think it'd be really rich for our group to have a more detailed conversation on that and to share more insights and learnings. I am cognizant of time and that we're at the top of the hour. I wanted to just flag a couple things before we wrap up. One, thank you all so much for joining us today. Thank you to our speakers. Putting on my R4D hat for a second, thank you so much to everyone who contributed to the market assessments. We have Ozzy here from Market Access Africa, Chris from Pract Health, a number of other R4Ders who also contributed to the work, and then the Maisha team as well, and then not to mention our country partners. So really appreciate everyone joining. I want to call attention also, now I'm putting back on my MHS caucus hat, call attention to 2 upcoming convenings hosted by the Maternal Health Supplies Caucus. So next week on June 4th, we have our bi-monthly members meeting. Anyone is welcome to join. If you're not registered to be a member of the caucus, please do so on our website and you can be receiving those invites. We're going to use that time to do some lightning updates from a number of different partners to share ongoing activities and initiatives in the maternal health space. And then the following day on June 5th, we have a fantastic webinar planned with colleagues from Concept Foundation, where they will be sharing out findings from recently published studies in Ghana, Nigeria, and Senegal, which illuminate the economic rationale for investing in quality assured uterotonics. So if you're interested in picking up on this quality discussion, please do join us on June 5th. With that, I will say thank you again. Really appreciate everyone joining today and hope you all have lovely Thursdays. Laura, anything else you want to wrap us up with?
No, thank you everybody for joining and thank you to our speakers. Have a wonderful rest of your day.
Awesome. Thank you so much, everyone. Take care.
Thank you.
Thank you.